Critical appraisal of research literature. This is something that every medical graduate should know, because once you finish your education, you will need to continue your education forever, really. And you will do it through following what's being published in the literature and appraising whether you can trust the papers that you're reading or not. So you have to develop your own kind of understanding of what makes a paper trustworthy, reliable, good paper, and what does not, and why you should believe something and why you shouldn't. Based on those kinds of decisions, you will change your practice, you will change your approach to treating your patients. So you need to be able to become critical about reading papers that other people write. So let's see how to do it. Sometimes you're going to serve as a reviewer, so this is certainly going to help you to know how to approach reviewing any research paper. So the aims of this lecture is to prepare you for an in-course assessment, which will be basically a critical review of a paper. The key objective of this whole module is to allow students to critically evaluate the published medical literature. An in-course assessment will require you to recognize the design of the study, to recognize the strengths and weaknesses of the study from the perspective of its aims, objectives, study design, quality of data, and appropriateness of the methods used. You will need to explore the possible effects of chance on the reported results, explore the possible effects of bias, explore the possible effects of confounding, assess whether there are valid arguments to support any causal inference in the paper, and finally reach your own critical conclusion about the overall value of the study and its realistic contribution to the overall biomedical knowledge. All right, so that's what you should know after this whole course. This is what our in-course assessment looks like. We pick a paper and you need to give us the recognized type of study, the hypothesis correctly spelled out, identify 5 key strengths of this study, 5 key weaknesses of this study, whether there is any effects of chance that are likely, whether bias is likely, whether confounding is likely, and then overall conclusion, is it a true contribution to knowledge or too burdened with problems to be trustworthy? Total word count of your review of the paper needs to be about 750 words, and you will get a structured mark because you will know exactly for each of these how many marks did you get and where did you lose your marks. So that is how we do it here when we assess. So biomedical literature, as you know, is daunting. More than 4 million papers were published annually 10, 15 years ago. Now it's many, many more. Spending 15 minutes on each article in only 10 specialist journals would occupy half of any clinician's working life. But now it's even worse because these data are from about 10 years ago. Now it's even a lot worse. So how do you approach articles? Firstly, you screen the titles. You type something of your interest in the PubMed and you see what articles come out and you just screen for your titles. Once you think that some title is relevant to what you want to find out, you read the abstract of the study, and if the abstract is interesting, you continue reading and look into tables and figures and then maybe read the entire paper, even look at the references. Okay, so what does your critical appraisal of a paper assess? It tries to determine if aims, methods, and results of a study are sufficiently robust to provide useful information. But what does it not assess? It doesn't assess if authors are generally good scientists, okay, or if they come from a decent institution. So you should not be biased by that. If the scientists were good so far, this doesn't mean that this paper is also good. If the scientists come from top university, this doesn't mean that the paper is also good. And as editors of the journal, we do see this a lot, that sometimes we get papers by good scientists or papers by from top institutions for whatever reason they are publishing this paper, but it's just not a good paper. You know, we're trying to be positive, but it's not a good paper. How well is the article written in English or other language? So we're not assessing whether the use of English was good. That should not be the reason why the paper is rejected. How visually attractive and colored are the figures and the tables, and how complete the references. We want to point to these things if We must, but that's not going to lead to a decision or influence the decision whether the paper is going to be accepted or rejected, because these things are irrelevant to the information and knowledge that paper is trying to generate. So how do we do this? Because each paper is different and because there's so many of them, we try to use the algorithm, the nuts and bolts approach, because all papers have different strengths and weaknesses, so therefore it's best to use the guideline checklist or algorithm to appraise it in a systematic, standardized way so that you remember everything that you've done and you don't overlook anything. You have the red booklet which we prepared for you, which offers help and guidance about how to do this. All students should use it as an independent source, and on pages 128 to 132 you have a paper by Professor Jerry Fowkes in BMJ from 1991 where he explained, I'll go back to that paper, that's the paper, Critical Appraisal of Published Research, Introductory Guidelines. That paper is very useful because it takes you step by step through how do you appraise a paper when you're a reviewer, all right? So this is how you do it. Firstly, think what are the aims and objectives? What is the main research question and hypothesis? Is this clearly stated? If it's not clearly stated, then you should tell the authors to clearly state it, because many papers don't have it stated. They just start talking about something without ever explaining what is the aim and what is the hypothesis, okay? What is the design of the proposed study? It has to be clear. Is this a prospective, retrospective, randomized control trial? What is it? Then, importantly, ask yourself, now that you understand the objectives and question and the design, is the design appropriate to address the stated objectives and answer the question? Because many times people try to answer the question without applying the correct design, or try applying the design without being able to address the question. Now that you've passed that, think about the sample that you are using. Is this study sample representative of the general population? Are you going to be able to generalize these results? If not, why not? Which is fine, they don't have to be. If we're talking about context-specific research, then it don't have to be. So think about source of sample, sampling method, sample size, entry criteria, and any non-respondents. Why did people choose not to respond? Are you using systematically some people who are different and this is actually skewing your results in some way? You know, then is control group acceptable and comparable to cases? If this is a case control study, please think carefully about the control group. How did you define controls? What is the source? How did you do the matching? How did you randomize? Then, once you define the people you're studying, what is the quality of all the measurements and all the outcomes? What is the validity, reproducibility, blindness, quality control, everything that's related to the information that you generated that could somehow affect it? Is the data set upon which the study is based, is it complete? Is the data set upon which the study is based, is it complete? What about compliance, dropouts, deaths, and from other causes, or any missing data? Because this incompleteness of the information, which is almost always present in each research, usually is affecting the results and the conclusion. And then what could be the other distorting influences on results, such as chance effects, too small study, bias in design, confounding factors, any other external factors, contamination of the data, changes over time, distortion reduced by analysis, and anything else. And finally, you pass the overall judgment on the study in view of all this. What are some typical strengths of a paper? This is back to writing your own discussion, which we were just discussing. So this is telling you how to write that part of the discussion. So very large sample size, that would be a strength. First application of a completely novel research technology. Clever use of large existing data sets to address completely new problems. Clever, elegant study designs. Unique opportunities to seize the context and conduct some natural experiments. Providing first ever information on a new problem. Multivariate statistical analysis to control for confounding, and prospective studies with a long-term follow-up or user large population registers that encompass the entire population. Those are typical strengths of studies in medical and health and global health research. But what are the typical weaknesses? Well, weaknesses are far more difficult to spot, and they can be much, much more diverse. This is why it is best to use algorithms to detect them. Most serious concerns would be related to chance effects, so findings being statistically significant only due to randomness. When sample is too small, the risk of false positive result, as we have shown with rolling the dice, is always increased. Bias is a flaw in a study design which leads to statistically significant findings and rejection of null hypotheses, although there is no real difference, all right? So this can show and imply the difference, although the difference is non-existent, but there's something wrong with the study. And confounding is a statistically significant association between A and B, which is actually due to their link with a third variable, which we didn't use, and there are no real effects or correlation between A and B when this variable is absent, all right? So let me explain how big effect chance can actually have and how big sample sizes do we really need given how everything is correlated in the body and in biomedicine. So let's look at the association between blood pressure and body mass index. Let's look at the result from a small study. Small study looked at this in 1,000 people. So notice that I'm calling 1,000 a small number because, you know, there's just so many effects, and environmental effects and biological effects and genetic effects and cultural effects and social effects that there's just a mess, and you can't ever have a clear relationship. But look what this study found based on 1,000 people. That body mass index, if you go and interpret your results, you're going to say like, body mass index does increase blood pressure to an extent, but then once you become obese to this level, then actually there is a plateau. And now you start going half of your discussion about what could be the cause of this plateau. And then there is a second plateau after which, again, it has the influence. So this is something you can get out of 1,000 people. But then somebody says like, come on, let's do the study on 5,000 people, and you get this. Oh. And then now you're interpreting, no, this study clarified the picture, right? This study clarified the picture, and actually, you know, those plateaus we thought are plateaus. No, in fact, there is a bump in the beginning in people who have very small body mass index, but then you have a very steep increase, and then suddenly, counterintuitively, you actually have in very obese people a decrease in blood pressure, and then goes up again. So interesting, right? Then you do the 10,000 people and you get this. And like, So actually we were wrong before. There is a U-shaped curve, you know, which means that the really people with a low body mass index have a slightly higher blood pressures. That's really interesting. But then, you know, it's a U-shaped curve. It goes down and then it goes up much more clearly, you know, so clearly it just always goes up. There's no plateaus, no bumps, no nothing now that we have more people. But now we can also see finally very clearly that there is a U-shaped curve. And then you read all this nonsense really, because what you need is 500,000 people. And when you have 500,000 people, then everything becomes crystal clear. You know, the bigger the body mass, the bigger the blood pressure. And it only makes sense. Why? Because, you know, the more mass for which the heart needs to pump the blood, the higher pressure it needs to pump it through the whole mass and bring it back into the heart. So clearly, you know, the more mass to pump through, the bigger the blood pressure is required, and heart compensates for body mass index increase by creating bigger blood pressure, you know, pumping harder. And it's all very clear when you have a sufficient sample size, because then all these noises cancel each other and you get a very clear answer. But these noises are very present and they don't cancel each other when you have smaller sample sizes. By smaller, I mean even 10,000 people or 5,000 people or 1,000 people. That is not a large sample size. So I hate seeing people submitting me a paper and saying we use a very large sample of 1,700 people. That is not a very large sample. You know, in epidemiology, with all the chaos and all the effects, that's not a very large sample. So what we are considering a very large sample is hundreds of thousands of people, and then you get much clearer results. So this is how much you need to get a really clear answers in epidemiology. So bigger is always better, remember. Now, let's explain bias. There are all sorts of biases. There are so many biases that have been explained or reported. So case selection bias, what would this be? Let us see what case selection bias is. So this is the proportion of epileptic seizures, and this is the risk of epileptic seizures, absolute risk obviously, following febrile convulsions. So you have a small child, the child gets a fever, the fever doesn't get treated, doesn't get reduced, and then little by little you have a risk that you will get the child will get febrile convulsions, and this can lead to epileptic seizures. It's a very dangerous condition. You have to take the child to the hospital. So what's going on? These are clinical-based studies from the hospitals. What is in population-based studies that were done in the community, what was found? So look at this. Proportion of epileptic seizures in kids which develop febrile convulsions. So population-based studies with a very narrow confidence intervals are saying that it's about 11% maybe. All of them are kind of, they're 10%, 11%, all of them agree. But look at these studies. What's really funny is how this study is claiming that the confidence interval has to be between 62% and 70%. And these confidence intervals here have absolutely nothing to do with these confidence intervals there, and they're measuring the same thing. So something is clearly wrong. But do you remember the story about the exact color of the sky? You know that they may not be wrong, they may not be cheating, these may be real observations. So something is clearly wrong. What is wrong? What's wrong is that in the population, when child have febrile convulsions, people will really take their kids to hospital if they see that something is terribly wrong. So you are not taking all the kids to hospital. You are taking a very small subselection of kids to hospital, which are the most severe cases. So in hospitals, you always cluster most severe cases, and you should never make projections about the whole population based on hospital-based studies, especially when you don't get all universal access to healthcare, because hospitals concentrate people who felt at home that they could no longer deal with the problem, and even their GP couldn't deal with the problem, and they end up in the hospital. That means that the problem suddenly became so severe that everyone thought this should be rushed to hospital. And then when you look only at the cases that hospitals see, they're always far worse than the cases in the general population really are. So this is your bias here. So these studies were actually published, but no one thought how phenomenally biased they could be. All right? Now, another kind of bias is recall bias. We want people to remember something, and memories are very, very, very subjective and inconsistent and unreliable. Memories are phenomenally unreliable, human memories. So we would like to know whether exposure to irradiation in pregnancy could have led to brain tumor in a child. All right, so that's our research question. The research question is, does exposure to irradiation in pregnancy lead to brain tumors in the child? But the trouble is that you will certainly have mothers having a huge recall bias about this, because the mothers whose child has a brain tumor will remember every tiny exposure to radiation she passed in front of a television, whereas a mother who was taking sandwiches to a husband who works in nuclear power plant will not report it because she has a healthy child, so she won't think about it. So what you need some sort of a multiple control groups which can help you to understand this bias a bit better. So let's say that it was 20% of mothers whose child has a brain tumor that reported irradiation, exposure to irradiation. And then you introduce this group where child has some other tumor, not brain tumor, and if they said 20%, and if the mothers whose child is healthy also say 20%, if this happens, then that means that irradiation can't possibly have any effect on the brain tumor development, because all of these three diverse sets of mothers report the same level of exposure. But if the child mothers with healthy children reported in 20%, and mothers with child has brain tumor and child has other tumor reported both with 80%, that could mean two things. That could either mean that irradiation has a non-specific effect on all cancers, but we know that it doesn't, all right? We know that it doesn't. Or it could mean that mothers whose kids have cancer simply have a phenomenal recall bias about this. But since we know that not all radiation the radiation doesn't cause some cancers at all, so if the mothers whose children have that cancer report high level of irradiation, that means that they're biased. And based on their bias, we can then understand what is the likely part of the bias in the mothers with child with a brain tumor and what is the exposure. And here, clearly, there is no difference at all. So we can assign this to recall bias. We can't assume anything from this. But if you get this, which is that child is healthy 20% and child has other tumor 20%, and child has brain tumor 80%. That then tells you that there is no recall bias here, because mother with child with other tumor would also report it, but that actually genuinely 80% of mothers with child with brain tumor were exposed to irradiation, and this would be telling you that irradiation is probably a very important risk factor for child's brain tumor, okay, whereas these are not, okay? So this is why you need multiple control groups in your study design. This is a well-designed study because it controls for recall bias, which it knows would be there, all right? Then explaining bias and confounding in the same example. This is a really good example. So somewhere in the sometime in the 20th century, there was a lot of interest in pancreatic cancer because this was the worst possible cancer really you could get. I mean, there are some theoretically possible that are even worse, but pancreatic cancer is to this day really like the worst cancer, because the survival is 6 months, you know, at best. Maybe someone makes a year, but it's awful because it's just so silent and spreads in the middle of everything so quickly that there's nothing really you can do. So association, one study looked at whether coffee drinking, so there was huge interest in what could be risk factors. Since we can't do anything to treat it, well, then at least can we prevent it somehow? So coffee drinking was explored, whether it could cause pancreatic cancer, and the study showed that actually people who drink coffee have higher risk of pancreatic cancer. Oops. And the coffee industry was freaked out because they didn't want this to be all of a sudden associated to coffee. So this was a very serious study, actually. This was a case control study conducted in 14 US hospitals. So a lot of pancreatic cancer cases were assembled, and a lot of well-matched controls were assembled, and it was clear that when you ask pancreatic cancer cases how frequently they drank coffee far more frequently than all of the controls, all right? And this was striking effect, and they couldn't explain it in any way. So the coffee industry got scared and really worried about this, so they paid some epidemiologists to try to refute this study, all right? So they looked at this and they said, like, well, you know, people who drink coffee usually also smoke when they drink coffee, so maybe it's smoking rather than drinking coffee that causes this. And then they went back and asked all the people in great detail about their smoking habits, and they were exactly the same between cases and controls. Just the coffee drinking effect remained. And then the coffee industry got really worried about this, and then they paid a lot of money for the best possible epidemiologists they could find and asked them, please find anything wrong with this. You know, this is a disaster for us in terms of image. And then they looked at the design very well, and they started thinking, okay, so what would be the ward to which you would admit a pancreatic cancer case? It would be gastroenterology ward, all right? Okay, so they were all admitted across all hospitals to gastroenterology ward. So an admitting physician would then be admitting the case, and then that same physician was asked to pick a control because it would be unlikely that the control would decline participation because that's their physician. So the gastroenterologist was picking the control, and he went to his ward and looked for the person who is the same sex, the same age, the socioeconomic status, the same everything else, the most similar, and he picked the control. Now, you need to ask yourself, what kind of people were actually lying across gastroenterology wards in those days? Sorry? Gastritis? Ulcer. So it was all ulcer. You know, they were coming in the 13th, 14th, 15th visit. It was all peptic ulcer. That was vast majority, by far the biggest reason of hospitalization in gastroenterology at the time was peptic ulcer. And when you release the person with peptic ulcer from the hospital, what does the doctor tell them? They tell them to avoid, well, anything that can make it worse, but most of all, coffee. So if they're now coming to the 10th visit to the hospital and their doctor, who told them last time when they were discharged, told them not to drink coffee, and now he's asking them, how much coffee did you drink? What are they going to say? They're going to say very little or nothing, all right? So this is where the difference came from. You know, they were asking people who were forbidden to drink coffee how much coffee they drink, and this was their control group. So this was a flawed study, and when they looked at how much general population drink coffee, the pancreatic cancer cases and the coffee drinkers were exactly the same. So this is an example how confounding and bias can influence results. Look at the results of the presidential election, Obama versus McCain. If you you can see that all the states which have some coast, you know, some water, which border some water, vote Democrats, and all states which have no border with water, or almost all, voted Republican. So if you did a study, you know, you could find the p-value very small that any a state which has a border with the water, like these lakes here and this and this and this, will actually vote Democrat, and any that doesn't vote Republican. And you see, I mean, this could be a study. You can get the p-value, and you can then start looking for plausibility, why this is, and so on and so on. But that's silly, you know, because clearly there must be some confounding effects, and it's not the border with water that makes people vote Democrat or Republican, okay? It's something else. So this is an example of confounding effect. So I'll just give you an example from the last year of the paper that we had to assess, or the students have to assess. The aim of the paper was to explore possible association between hair dye use and breast cancer occurrence among Finnish women in Finland. So the hypothesis was that the remnants of prohibited aromatic amines found in many hair dye products may be carcinogenic and affect breast epithelial cells, leading to elevated levels of DNA adducts and increased cancer risk. All right. The type of the study was case control study, these were the strengths of this study. It was population based because Finland has cancer registry. Controls were representative of the general population. They were matched by age from the registry. No ambiguity in case definition. This is great. You know, case definition, breast cancer, you either have it or you don't. Then attempts were made to characterize the suspected risk factor quite well. So the study really looked in great depth about what kind of hair dyes were used, how much, and so on. Detailed questionnaire. Controlling for multiple sources of bias, controlling for multiple sources of confounding, and trying to avoid misclassification bias. But the weaknesses were, questionnaire was self-administered, you know, so women could answer whatever they wanted. Response rate was considerably smaller than 100% in both cases and controls. So for some reason, some ladies didn't return their questionnaire, and now you don't know whether they were there was any systematic bias. Response rate was considerably different between cases and controls. This is not good because that may shift the percentages. The collection of cases was incomplete because 1,550 women had died before the start of the study, so you can't know whether in their case this was always also true. The study only included cases and controls they were aged 22 to 60, so didn't look younger or older. The risk factor of interest is difficult to quantify, which is exposure to hair dye. How much do you actually breathe in, or whatever else the mechanism should be. And the results in Finland clearly may not be representative for the rest of the world. So this is how you assess or appraise a paper. Okay, the last slide. I'll teach you the Bennett's classification for reading medical articles. Medical student reads entire article but doesn't understand it, all right? So that's you, right? Then house officer uses journal as a pillow during nights they spend on a call, right? Then registrar skips articles entirely and just reads the job adverts in the biomedical journal. Then research fellow reads entire article and reanalyzes statistics. Then consultant reads references to see if she or he has been cited in the paper. That's the only thing they care about. And finally, retired physician reads entire article but doesn't understand it, just like the students. So this was published in Journal of American Medical Association in 1992. Very true, actually, very true. Thanks very much for your attention. All right, thanks.